Hello and welcome to Inovi Fertility and Genetics Institute. This is Dr. Kroetz and I'm here to talk about the benefits of fertility treatment today. So many of you may be wondering, what are the benefits of fertility treatment? And of course, we know what the obvious answer to that is, and that is to get pregnant and to have a baby. But of course, there are several other benefits to having fertility treatment that may be a little bit less obvious. And so we're here today to talk about some of those, and then of course how you can best prepare to start your family. Now, when we talk about what are the benefits of fertility treatment, I would basically break them down into, number one is going to be diagnostic evaluation. In English, that means figuring out what's going on with you and your partner and where you're at. And then number two would be family planning. Family planning is the other big topic that is very important in fertility, and I think a lot of us could benefit from hearing, especially at a time before we're considering having a family. So a great time to get involved with family planning would be to start thinking about it at age 25. So first off, what is the diagnostic evaluation and who should get it? Well, a lot of women, their first experience with OBGYN is when they go to get their annual pap smear. And the average age at the age at when you're supposed to first get your pap smear is age 21. And that's what the American College of OBGYN recommendations suggest. I think one of the things that's lacking in education in high school and even in college is that women should also be advised about their fertility and how to preserve and protect their fertility. One of the things that I would recommend for all women who are thinking they may conceive in the future is to consider getting their fertility checked around the age of 25. And this really can start out with a simple visit to your OBGYN or your fertility specialist, and then also going ahead and checking the AMH value. Now, a lot of you may have already heard about AMH or have probably heard me talking about AMH frequently, but AMH is such a great test because you can walk into your doctor's office and you can ask them to check your AMH on your first visit. And the AMH, for those of you who may not remember or who are joining us for the first time, is your anti-Müllerian hormone. And the anti-Müllerian hormone gives us a rough estimate of your ovarian function compared to your age. So for women that are of the age of 25, their AMH levels should on average be between 2 and 3. And then women who are at the age of 35, their average AMH will be around 2, and those who are 41, it will be 1. Now, AMH doesn't actually give us an egg count, but AMH gives an approximation of how your egg count is relative to others in your group. If your AMH is lower than expected for your age, then that can be a warning sign for you that it may be a good idea to go speak to your fertility specialist and learn what that means. Other things that are important from your history also can be a family history of premature menopause or early menopause, and that is women that have undergone menopause at the age of 40 or younger. So AMH, I would say, is a great thing to get, and I would say it's critical and it should be considered as a part of all women's care. And I would say the ideal age to get the AMH is around age 25. The great thing about getting the AMH then is it also allows you to know where you're at, and you can also use it to start a conversation with your OBGYN or fertility specialist about where you are at in the whole fertility process. Now, we talked about, what are the benefits of fertility treatment, and obviously, like we said, the main advantage is trying to get pregnant, but also it's learning about yourself, learning about your body, and making plans. So as part of the other diagnostic workup, another thing that's important to check is your fallopian tubes to make sure that they're open. So if you're thinking of conceiving within the next year or two, then checking your fallopian tubes with a hysterosalpingogram is a great thing that you can do to figure out if your tubes are open. And the third thing that I would say would be important for a couple is to go ahead and get a semen analysis, and the semen analysis will then tell the male partner if his sperm count is adequate, and we're looking at the total number of moving sperm, and then we're also looking at what's called the strict morphology. And the strict morphology is the number of perfectly shaped sperm. So one of the biggest advantages to beginning fertility treatment or thinking about fertility treatment is going to the doctor and finding out where you're at and if there are any issues that need to be fixed. Because if you address these issues early on, then you may need less aggressive treatment in the future if it turns out that you need to undergo fertility treatment. So a lot of times patients or their partners may think, well, I don't want to go to the fertility doctor. I think that, they're going to start us on treatment right away, or it may be costly. But the flip side of it is that a lot of people delay going to the fertility doctor for 3, 4, 5 years, sometimes even longer. And then in the end, it ends up being more difficult or more costly because the types of treatments and the things that they have to do are more involved. Now, one of the big things that we're talking about lately is egg freezing. And why I mentioned the AMH is the AMH can let you know what your egg count is like. And especially in cases where a woman's egg count is going down more quickly than expected, the AMH can also help a couple decide when they should have children or if they should consider seeing their fertility doctor sooner than later. So the AMH is a very good first step. And that leads to our next topic, which is egg freezing. So egg freezing is something that has been in practice and has been a lot more common in the past 8 years. And even in the past 5 years, the numbers of people that are undergoing egg freezing has tripled. And so a lot of times women think about egg freezing when they hit the age of 35. And that's when they think, well, if I don't have a partner or if I have no immediate plans to get pregnant, that's when I should consider egg freezing. And really the truth of the matter is that egg freezing should be a consideration for most, if not all, women. And the reason being is that whenever you're considering egg freezing at age 35 or later, then your fertility has already started to decrease, and the results from egg freezing may not be as good as they had been if the patient had been more proactive. So currently we say the ideal time to egg freeze for a lot of women is around the age of 30 to 34. Although the truth of the matter is, if women were to consider it more between the age of 25 and 30, that would really be the ideal time to do it. And why is that? That's when your pregnancy rates are highest using your own eggs. So let's say you decided that you were going to be proactive and you froze your eggs at age 27. You could come back and use those eggs later on to conceive at age 37, at age 42, even at age 47 if you really wanted to. And the chances of you getting pregnant would be the same as if you were 27. And if you do the egg freezing when you're at age 27, your number of eggs that you freeze may be much higher. So when we talk to women about egg freezing, we tell them the ideal number of eggs to freeze is ideally 20 to 25 eggs. And typically that requires undergoing egg freezing 2 times on average. So if you start off when you're younger, 25, 26, 27, and you undergo egg freezing, then the chances of you getting a higher number of eggs are much higher than if you had waited 10 years down the road just because you were uncertain if it was something that you wanted to do at that time. If you had waited 10 years down the road, you may, for example, get 10 eggs as opposed to getting 16 or more eggs if you had done it when you're 25 or 26. So that's really where thinking about this early on is really a great idea. And so when you decide to do egg freezing, you're really taking control of your future, and you're also taking control of your choices in the future. Now, one of the other things too people are often wondering about with egg freezing as well is that, so what if I don't need the eggs? Well, if you decide in the future that you get pregnant on your own, or you never have any issues with infertility, it's always nice to know that you had those eggs as part of your reassurance plan. In other words, it's never 100% insurance plan what it is, a way for you to feel better about your future and to know that you've done something proactively to increase your chances in the future of having a baby. So the next thing that we often can focus on besides egg freezing is fertility treatments. Now, before fertility treatments, like we talked about, you want to undergo diagnostic testing. And diagnostic testing, like I said, one of the big advantages is that you get to know where you are at. And even if you just went to the doctor and did your diagnostic testing and you didn't go with fertility treatment, you would still be taking a big step forward in taking care of your fertility and also being informed and preparing for the future. So insemination, a lot of people may wonder, well, what's the advantage of doing insemination? Well, insemination is a treatment that is often combined with ovulation induction. And what does ovulation induction mean? It means taking medicines that will help develop eggs and help you ovulate. Nowadays, when people are trying to get pregnant, they often combine ovulation induction with superovulation. So in English, it means we're not just giving you medication to help you produce one egg, we're giving you medication to help you produce multiple eggs. So a lot of you may have taken clomiphene or letrozole in the past, and a lot of you may start off with one pill, but really to increase your chances of getting pregnant, you should typically start off with 2 pills, which is Clomid 100 milligrams or letrozole 5 milligrams total. And so what the insemination does is the insemination can double your chances of getting pregnant whenever you're using Clomid or letrozole. So with Clomid or letrozole, your chances of getting pregnant per try is around 4%, and when you add insemination, then it doubles up to 8%. Now, a lot of people may say, well, 8% is not very high, but for most people, if they've been trying for a year, their chances of getting pregnant per month is about 0.5% to 0.2%. So that kind of treatment represents already around 15 times better than what they have done in the past on their own each month. So the big thing or the great thing about the insemination with ovulation induction is it's very easy to do. It takes only 5 days of medication plus usually the medication to release the egg at the end. And it significantly increases your chances of getting pregnant. Now, how does the insemination itself help? Well, usually what happens when people have intercourse, the sperm is placed next to the cervix, and then the sperm, a lot of them get trapped in the cervical mucus, and then a few of them get through and swim up to meet the egg. So typically, if a man has around 15 million sperm in the ejaculate, and then they have intercourse with their partner, typically only 500 find the egg. Well, the great thing is when we do the insemination, then we place all of these sperm, millions, tens of millions of sperm inside the uterus, and then those sperm are able to find the egg. So instead of getting 500 sperm finding the egg, we're getting 5 million, 10 million, sometimes 15 million sperm finding the egg, which is great. And that's how insemination can really improve your chances. So finally, the other question that we get, of course, and a lot of people wonder is, how does IVF really help your chances of getting pregnant, and what are the benefits of doing that? Well, obviously, the main benefit of doing IVF is to get pregnant, but there's several other benefits that are often not talked about. One, when we do IVF, we can find out a lot of the reasons why people were having problems conceiving in the first place. So whenever you do insemination or you take Clomid or letrozole, we can see how many eggs develop and how you respond to the medicine, but that doesn't give us any information about the egg quality or the sperm quality or the sperm-egg interaction or how the embryos are developing. So once the egg is fertilized by the sperm and it develops, then we really get an idea of what the egg quality is like. So when we do IVF, there are several things that we get to see that are different, right? So the first thing is we give the patient medication and we really get to see how they respond to the medication as opposed to just the oral medication by itself. Now, typically with oral medication, most people will get anywhere from 1 to 2 to 3 follicles. But when we do IVF, we give them a lot more medication with the goal of getting at least 8 to 15 follicles. And when we get that many follicles, we can really see how patients respond as we watch the follicles develop and as we check their blood results. Then the next part of the process is the retrieval process. So typically we say for each follicle, there's about an 80% chance that there is an egg inside the follicle. So remember, the follicles are the little fluid-filled cysts on the ovary where the egg is developing. So once we retrieve the eggs from doing the procedure, then the eggs, we can see the number of eggs that we are able to retrieve. So if somebody has eggs in only half the follicles, then we already know one of the problems is the development of the follicles. We can also get a good look at the quality of the eggs as well. So we look at the eggs and we see, are a lot of the eggs immature, or are they mature, or are they what we call post-mature? And we can also see if they look normal, or if the cells surrounding them are dark, which are called accumulus cells, and that is also an indicator of low egg quality. So after the eggs are retrieved and we look at them and we assess the egg quality, then the cells are taken off from around the egg and the sperm is directly injected in the egg in a process called ICSI. Now this process allows us to see how the machinery in the egg is turned on after the sperm is injected into the egg, so we really get a sense of egg quality and the ability of the eggs to be fertilized. In some programs, the scientists put the sperm outside the egg and they allow natural fertilization to happen in the IVF lab, and that also can be an indicator of what's going on. So for example, if you were to take half the eggs, and let's say you had 10 eggs and you allowed 5 to be fertilized by the sperm just sitting next to the egg, and then you injected 5 eggs with sperm, and then you saw a big difference in the number of eggs that were fertilized from injection compared to those that were placed next to the egg, then you would definitely know there's a problem with the sperm and the egg interaction. So typically when we see the egg injected with the sperm, we expect about 80% of those eggs to be fertilized, but when we put the sperm next to the egg, we may see 65%. So if we were to put the sperm next to the egg and we only saw that 20% of the eggs were fertilized, then we know there's a problem with the sperm getting into the egg or how they're interacting. So that would give us more information as to why the couple couldn't get pregnant in the past. So after the egg is fertilized, we watch it develop in the lab for 5 to 6 days. And so in that point, we can get a lot of information just watching how the embryos develop. And remember, the embryos are the fertilized egg. So we watch them, and they're typically checked on the first day and sometimes the third day, but they're always checked on day 5 and day 6 after the retrieval. And at that point, a day 5 or day 6 embryo can be transferred to the uterus, or it can be checked genetically to see if it's normal. Now, a lot of the embryos that don't make it to day 5 or 6, it's because they're chromosomally abnormal. So if we start off with 10 eggs, then we may expect maybe 30 or 40% of those eggs to develop into an embryo. And then those embryos can be checked in a process called pre-implantation genetic diagnosis, and then we can tell if those embryos are normal. And when we see if the embryos are normal, that also gives us an idea basically of what the egg quality was. So if the egg quality was low, then a low percentage of those embryos that are checked with a biopsy will be normal. If the egg quality is high, then you typically will have more embryos, and you'll typically have more normal embryos. So the IVF process can give us a lot of information about what has gone on. For a lot of patients, it will actually give them closure as to finding out as to why they were not able to get pregnant before. And then it gives us a lot of information that we can use to help the patient get pregnant with that cycle, or in cases in which there were few embryos, how things may be improved in the following cycle to help them conceive and have a child. Now, the other thing about IVF that we a lot of times attribute to egg freezing is that IVF can also be a method of what we call fertility preservation. And fertility preservation is when we preserve your fertility for the future. And basically what that means is that you can undergo IVF, but it doesn't mean that you necessarily have to transfer the embryos right away to try to get pregnant. So, for example, if you are the age of 38, 39, or 40, and you feel that you want to have more than one child, you want to have 2 children or 3 children, a lot of times what's recommended is that women consider embryo banking. And embryo banking allows you to basically create these embryos and then to store them for future use. So, and the reason that you may do that is because if you were to just go ahead and transfer the embryos right away without banking as many embryos as you can, then you may not be able to get pregnant when you come back in 2 years to conceive again. So somebody that's 38 or 39 and they're already having difficulty getting pregnant and they're able to conceive with IVF but didn't have many embryos, if they were to get pregnant right at that point, then in the future when they come back in 2 years, then they may not be able to get pregnant on their own, and then even if they do IVF, their chances will be lower. So a lot of times what we recommend patients do is something called embryo banking, and we ask them to bank approximately 2 embryos per baby that they would want to conceive, so that they're able to conceive once, and then in the future when they come back, especially if they have low fertility, they'll be able to conceive with those embryos that they had already stored from before. So I think embryo banking is a very powerful thing, especially in women that have a low AMH that's lower than 1, or if they're approaching the age of 40. Now, over the course of the week, we did get some questions about IVF and frozen embryo transfer, and why is frozen embryo transfer done a certain way. So typically when we have patients do frozen embryo transfer, there are several medications that we ask them to take. We ask them to take birth control, we ask them to take Lupron, esterase, progesterone, Medrol, and aspirin, which is, a lot of medications. And if you've ever looked at a frozen embryo transfer calendar, it's a pretty busy calendar, and it's easy to understand why sometimes patients can get confused when they're following the frozen embryo transfer protocol. So basically, we give patients Lupron to shut down their own hormones so that when we give them hormones to prepare the lining, that the lining is optimal for an embryo transfer. Okay? So prior to starting Lupron, we often put patients on birth control, because if we just started with the Lupron would actually cause their hormone levels to increase. So birth control starts off first by, quieting your system to some degree, and then Lupron really shuts it down. And it's during that first week of Lupron that most women have a menstrual cycle. Then after 1 week of Lupron, we give them estrogen, and this is the same exact thing that happens in a normal cycle, that estrogen levels go up in the first half of the cycle. So we typically give women 1 week of estrogen at a certain dose, and then we increase it the following week. So common type of protocol, which just basically means a recipe for IVF, is to give women 2 oral pills of estrogen a day for 1 week, and then the next week we increase it to 3 pills a day. So then after about 14 to 16 days of estrogen, which is the same thing that happens inside a woman's body, we have women start on progesterone. And progesterone is a medicine that actually makes the uterus friendly to receiving an embryo. It's the same thing that happens when you ovulate. When you ovulate in the middle of the month, an egg is released, and then the area where the ovulation happened, that follicle, starts to make progesterone to support any pregnancy. So typically the lining of the uterus has to be exposed to estrogen for 125 hours, which is 5 full days, prior to accepting an embryo. In some women, this window may be a little bit more, maybe 6 days, or it could be 4.5 days, and that's part of the reason behind doing what we call the endometrial receptivity assay, or ERA test. It's to figure out when is a woman's optimal window to receive the embryo. So the other question that we get is, what are we looking for? So we're doing all these ultrasounds, and you may wonder, what's the optimal lining? So typically what we tell women is an optimal lining for an embryo transfer is going to be between 8 millimeters and 12 millimeters. Too thick, I would say, is once you start to get to 15 or 16 millimeters. So women that have 13 or 14 millimeters is still okay. And we're also looking for the development of 3 lines. and that's what's called a trilaminar appearance. Now, if you're somebody that has been trying to get pregnant and trying to do a frozen embryo transfer, and you can only manage to get your lining to be 6 or 7 millimeters, that doesn't mean that it's not going to work. It just means that the chances are going to be a little bit lower. The same thing that in some women, we aim for what's called a trilaminar or 3-line appearance on the lining. Some women may only have what's called a bilaminar or 2 lines, and some women may only have a unilaminar or just 1 thick line. Once again, that doesn't mean that it's impossible, you're not going to get pregnant. It just means the chances are lower, and that's just based on data that fertility physicians across the country and across the world have collected. So I hope that answers your questions about frozen embryo transfer. I did also mention that Medrol and aspirin are taken. That's also just to help with implantation. Aspirin tends to thin your blood so that it's less likely that blood clots form between the embryo and the uterus, and the Medrol suppresses your immune system so that there's less of a chance of the immune system attacking the embryo. Although the uterus is what's considered an immune-privileged environment. In English, that means that anything in the uterus is less likely to get attacked by the mother's immune system as opposed to anything that, the immune system may see in the bloodstream or in other places of the body. So I want to thank you very much for joining us today for this live about the benefits of fertility treatment and fertility treatment preparation, including diagnosis. Next week, on Tuesday, we're going to have a live webinar at 7 p.m. to talk about egg freezing, and so it's going to be an interactive event, and you can register on Eventbrite. Just look for Inovi Fertility and the egg freezing seminar, and we'll look forward to having you all join us next week. Thank you, and good night.